Hello, my name is Erin Childress, and I'm going to be going over exercise 1, the endocrine system, in this video. You can follow along in your lab manual on page 1. Make sure to take appropriate notes in your lab manual as I go into more description or more detail over anything that's in the lab manual. That is also fair game for the practical, what I say in this video as well as the information in your lab manual, so make sure you take appropriate notes. Now, the endocrine system is going to be one of two major control systems for the body, the nervous system being the other control system, but they're going to be very different. The nervous system is going to allow the body to change relatively quickly through electrical impulses, whereas the endocrine system is going to be a more slow and a longer term change than the nervous system because it's going to be dealing with hormones. Hormones are going to be those chemical messengers that the endocrine organs are going to produce and secrete to cause some sort of change in the body. So the nervous system is going to be a really quick, fast-paced change that the body needs, where the endocrine system is going to be a little bit slower, but it's going to allow for the change to be more long-term. Now, the first organ we're going to look at is going to be the hypothalamus. It's going to be inside of the brain. If you look at figure 1.2 in your lab manual, this dark area on this figure is going to be where the hypothalamus is. You can see it enlarged right here. The hypothalamus is considered to be a master organ for the endocrine system because it's going to be involved in the production and the secretion of a lot of different hormones in other organs. Most specifically, you can see in this picture, the pituitary gland, which is this area right here, is connected to the hypothalamus. The posterior lobe of that pituitary gland has a direct connection with that hypothalamus. So the hypothalamus is going to have control over the hormones that are going to be secreted from that posterior lobe of the pituitary gland. The anterior lobe of the pituitary is not directly connected like the posterior is, but the hypothalamus is still going to produce regulatory hormones that are going to regulate what that anterior pituitary gland is doing. The hormones that the hypothalamus secretes are going to tell the anterior pituitary gland how many hormones it should produce and how much of those hormones it should secrete into the body. The anterior pituitary gland is going to play a major role in a lot of other organs like the thyroid gland, the adrenal glands, liver, testes, ovaries. So in the whole scheme of things, that hypothalamus is going to have some sort of indirect control over these other endocrine organs because it's telling the anterior pituitary what to do. Now, I've pointed out the pituitary gland in the previous slide, but we're going to go into a little bit more detail. The pituitary gland, you might also see it called the hypophysis. That is also fine as a term if you want to use hypophysis on the practical. It's the same thing as pituitary gland. It is going to be connected to that hypothalamus by this stalk right here, this area of tissue. That stalk is called the infundibulum. And I want you to know infundibulum for the practical. So what you can do now is scratch off the word stalk in your lab manual on figure 1.2 and write infundibulum in its place. That's the term I'm going to expect you to know for the practical. Now, one thing I want you to notice when you get a slide of the pituitary gland in lab, this is what it's going to look like. There is going to be a slight difference in appearance between the anterior pituitary and the posterior pituitary. This is going to be due to differences in the embryological origin of these two areas. They're derived from different parts of the body, and I'll go into more detail about that in a second. But for now, I just want you to notice that difference in appearance. The anterior pituitary gland is going to stain slightly darker, and it's also going to have more blocky cells. They're a little bit more cuboidal in shape. whereas the posterior pituitary gland is going to stain a little bit lighter. The cells aren't as blocky. It looks a little bit more like nervous tissue than the anterior pituitary gland does. Now let's go into more detail with the anterior pituitary gland. You can also call the anterior pituitary gland the adenohypophysis. That's fine. This area is going to be derived from the oral mucosa in your mouth. About the 3rd week of development, it's going to start to form. This is going to be an outpocketing of tissue from the roof of your mouth. That's where the anterior pituitary gland is coming from. When you look at the anterior pituitary gland, I stole this picture from a different textbook. You can see 3 different regions on the anterior pituitary gland. We have the pars distalis, the pars intermedia, and the pars tuberalis. The pars distalis is going to be the bulkiest part of the anterior pituitary gland, and it is going to produce the majority of the hormones for this gland. The pars intermedia is going to be right next to that, right in between the pars distalis and that posterior pituitary gland. It's also going to produce a hormone. And then the pars tuberalis is going to be this little hook that's going to hook around the infundibulum on that posterior pituitary gland. That area does not produce any hormones. It's just there to anchor that anterior pituitary gland to the posterior pituitary gland. Now you can see a difference in the pars distalis and the pars intermedia on the slide. This is that same picture from the last PowerPoint slide. If we're looking at this anterior pituitary gland, the majority of that slide is going to be the pars distalis, which is that darker, more granular area. But you're also going to see on the slide an area that's in between that pars distalis and that posterior pituitary gland. This is going to be the pars intermedia that sits right in between this same part right here. On the slide, it can look a couple different ways. Some of the slides, that pars intermedia will have these big cysts, these big open spaces. Other slides will have just a cleft, a white line that's going to separate that pars distalis from that posterior pituitary gland. So on the slide, make sure you could distinguish anterior pituitary from the posterior, and then also distinguish the pars distalis of that anterior pituitary from the pars intermedia of the anterior pituitary gland. Now we're going to move over to the posterior pituitary gland. You could also call this the neurohypophysis. This area also is going to start developing about the 3rd week of development, but it's going to develop from the hypothalamus. That's why it has that direct connection to the hypothalamus. Around that 3rd week, it's going to start forming and growing from that hypothalamus. The hypothalamus is part of the brain, which is composed of nervous tissue. So it would make sense that that posterior pituitary gland also has the appearance of nervous tissue. What you're seeing in this posterior pituitary gland, all of these cells, they're not blocky like the anterior. These are going to be tons of glial cells. If you go back to AMP1 and remember what nervous tissue looks like, you have neurons and then you have the small glial cells that surround the neuron. In that posterior pituitary gland, you're just seeing the glial cells. You don't see any neurons, but you will see a bunch of the glial cells. So it'll have that same appearance. Doesn't stain as darkly because of that. Now that posterior pituitary gland is going to have 2 regions. It's going to have this inferior portion called the pars nervosa, and then it's going to have the infundibulum, which is that stalk. Those are the 2 areas that posterior pituitary gland is going to have. Now, unlike the anterior pituitary gland, which produces its own hormones, The posterior pituitary gland is not going to produce hormones. All the posterior pituitary gland is going to do is store hormones that are produced in the hypothalamus. So the hypothalamus is going to produce the hormones are going to travel down through that infundibulum, and they're going to be stored in the posterior pituitary gland. And then once the body needs it, it'll be secreted from there. But that area of that posterior pituitary gland does not make its own hormones. It does not produce its own hormones. So let's look at some of the hormones that are going to be produced in the pituitary gland. We'll focus on the anterior pituitary gland right now. It does produce several different types of hormones that are going to affect other organs. The first one we're going to see is the thyroid stimulating hormone. This is pretty plain and simple. The title and the name of this hormone is telling you what it's doing. It's stimulating the thyroid stimulating hormone. It's telling the thyroid gland to release its hormones. That's all it's doing. The growth hormone, this is going to stimulate cell growth and cell division in the body. This really increases once you hit puberty and you go through your growth spurt. It's going to affect all of the cells in your body, but it's really going to target the skeletal and the muscular system and allow that to grow relatively quickly. Now, HGH, human growth hormone, is an illegal substance that is used in sports. It can help increase strength and lean muscle mass, but it does give the individual taking HGH an unfair advantage, and it is banned in sports. The next hormone is going to be the adrenocorticotropic hormone. This is going to affect the adrenal gland, and specifically the adrenal cortex, which is the outer layer of the adrenal gland. And it's going to stimulate the production and the secretion of different types of corticosteroids. One particular one would be glucocorticoids. And it's going to stimulate that adrenal cortex to produce and secrete these types of steroid hormones. And we'll go into more detail about what these groups of steroid hormones do once we get to the adrenal gland. Next, we have the hormone prolactin. This is going to regulate mammary growth and milk production in females. It's also going to help with androgen production in males. Androgens are precursors to testosterone. It's what the body forms before it becomes testosterone. So it's doing different functions for males versus females, the prolactin is. The next hormone produced by the anterior pituitary gland is follicle stimulating hormone. This is going to regulate the hormones produced by the gonads. The gonads are going to be the ovaries in females and the testes in the male. And what this hormone is going to do, it's going to stimulate these gonads to develop gametes. Gametes are going to be the sperm and then the egg for the female. It's also going to help in the development of secondary sex characteristics that you see once individuals hit puberty. And in females, this follicle stimulating hormone is going to cause the follicles to develop and mature in the ovaries in post-pubescent females. Now, the luteinizing hormone is going to have a lot of similar functions as follicle stimulating hormone. It is going to act on those gonads to help stimulate the production of the gametes, and it's also going to play into the secondary sex characteristics. But one thing specifically for females that luteinizing hormone is going to do is it's going to cause ovulation. So luteinizing hormone, or an increase in luteinizing hormone, is going to cause ovulation in the ovaries. This is where the egg is going to leave the ovary and go into the fallopian tubes. In males, the luteinizing hormone is going to play in production of testosterone once that male is post-pubescent. Now, the hormones that I've talked about already, the luteinizing hormone, follicle stimulating hormone, prolactin, adrenocorticotropic hormone, growth hormone, and thyroid stimulating hormone. all of those hormones are going to be specifically produced in the pars distalis of the anterior pituitary gland. All of those hormones are going to be produced in that area. Now, this last hormone, the melanocyte stimulating hormone, is the only one in this list that's going to be produced in the pars intermedia, that little middle area in between the pars distalis and the posterior pituitary gland. Melanocyte stimulating hormone is going to be formed there. Again, this title of this hormone is telling you what it's doing. It's stimulating the melanocytes. So melanocytes are going to be the cells in the skin that play on your skin tone. Melanocyte stimulating hormone is going to stimulate those melanocytes to distribute on the skin, and it's going to regulate how much melanin that it produces. The more melanin produced, the darker the skin tone is going to be. So this hormone is going to regulate what's going on with those melanocytes. Now, just to reiterate, the anterior pituitary gland is producing its own hormones. All those hormones we just talked about, the anterior pituitary gland produce those. These next hormones that we're going to talk about are going to be produced in the hypothalamus, and then those hormones are going to travel down through the infundibulum and be stored in the posterior pituitary gland. That's going to be its little storage area. Now, the first hormone that we're going to see that's produced in the hypothalamus is going to be oxytocin. Oxytocin deals with milk letdown and labor contractions in females. And then the other hormone that hypothalamus is going to produce is the antidiuretic hormone. Antidiuretic hormone is going to decrease urine output by increasing water absorption in the kidneys. So as your blood is filtering through the kidneys, those kidneys are going to reabsorb the water in your blood. The more that those kidneys reabsorb, the less you're going to urinate. Now, that antidiuretic hormone is really going to kick in if you have decreased blood volume. If you have decreased blood volume, you want to retain that water in the blood, so it'll increase that blood volume. One thing that is going to affect that antidiuretic hormone is alcohol. Alcohol inhibits the production of the antidiuretic hormone. The result of this, if that antidiuretic hormone is inhibited, it's not telling the kidneys to retain water anymore, so then you urinate more. So the more alcohol you drink, the more it's going to inhibit this antidiuretic hormone, which tells your kidneys not to reabsorb water, which then causes you to urinate more. So let's talk about some things that can go wrong with the hypothalamus or the pituitary gland. This is going to give us our first clinical case, and you could look at the clinical cases on page 13 in your lab manual. This first one is called diabetes insipidus. Diabetes insipidus. Not the same as diabetes mellitus that we'll talk about in a minute. Diabetes insipidus is a result of damage to the hypothalamus or the pituitary gland, either due to head injury, some sort of infection, loss of blood supply to the glands, or tumors. Diabetes insipidus is going to cause that antidiuretic hormone to stop or decrease in production. So if you don't have that antidiuretic hormone, there's nothing telling the kidneys to absorb that water, and you urinate more. Some of the symptoms that you're going to see with somebody that has diabetes insipidus is excessive thirst. The person's really, really thirsty all the time, and a lot of times will crave ice water. And then the other thing you're going to see is excessive urine volume, which makes sense. If you don't have any antidiuretic hormone being produced, there's nothing telling the kidneys to absorb the water, which causes the excessive urine volume. The next clinical case is called pituitary dwarfism. This is a hyposecretion of growth hormone. So the body is not producing enough of the growth hormone. This could be congenital, where the individual was just born with lower levels of growth hormone, or it could be caused by some sort of damage to the hypothalamus or to the pituitary gland, which causes it to stop producing the growth hormone. Some of the symptoms you're going to see with an individual with pituitary dwarfism is a slow or flat growth rate. This would be less than 2 inches a year. But the proportions of the individual will be normal. The body will still be proportional to each other. The arms will be proportional to the trunk of the body. It's just the individual will have a shorter stature. Now, if caught early enough, if you look at blood tests for growth factors, insulin-like growth factors, and notice that they are lower than normal, an individual can go through growth hormone replacement therapy to get the amounts of the growth hormone that they need to grow at a normal rate. And a lot of times, if caught early enough, an individual that's been taking the growth hormone replacement therapy will have the same stature as other individuals of their age. Could be a little bit shorter in stature, but can, if taken early enough, the body will maintain the same growth as an individual with normal amounts of growth hormone. Now, just opposite of pituitary dwarfism is a condition known as gigantism. This is caused by a non-cancerous tumor on that pituitary gland. And this is going to cause pressure on that pituitary gland, making it produce more growth hormone. One thing to outline in your lab manual is this tumor that's on the pituitary gland causing this excessive growth of hormone, excessive amount of growth hormone is going to happen before puberty. Really want you to underline this. What you'll see in an individual with gigantism is excessive growth in height, particularly, and also growth in the muscles and some of the organs. The example I have here is Robert Wadlow. He holds the world record in height. One thing that's really interesting is at the age of 5, he was as tall as an average woman, which is kind of terrifying that a 5-year-old is as tall as I am or anybody else. The gigantism is really going to affect that height more than anything else. There is another condition that deals with excessive amounts of growth hormone, and this is called acromegaly. Acromegaly is caused the same way gigantism is, by a non-cancerous benign tumor on the pituitary gland, but in this case the tumor is formed after puberty. In gigantism, the tumor is formed before puberty. Acromegaly, the tumor is formed after puberty. Some of the differences in the symptoms are going to be excessive growth in the thickness of the bone, not necessarily the height, more how thick the bone is, as well as excessive growth in the muscles and the organs. The reason that these bones are becoming thicker versus becoming longer is after you hit puberty, your growth plates in your bones, your epiphyseal plates in your bones are going to ossify, and you don't grow anymore after that point. They turn to bone. So instead of causing that bone to lengthen, such as in gigantism, it's going to cause those bones to become larger. Some of the areas you would see the bones thicken is going to be in the face, in the hands, and in the feet. You really see an enlargement in some of those smaller bones. So now we're going to move back to our next endocrine organ on page 5, and this is called the pineal gland. This is a really small organ on the posterior side of the thalamus. Here's the thalamus right here. There's the pineal gland. This is going to produce a hormone called melatonin. Melatonin is your vampire hormone. Melatonin is only going to come out at night, and it really regulates your sleep-wake cycles, which are called your circadian rhythms. Whenever there's long periods of darkness, the melatonin is going to increase, and that melatonin is going to make you drowsy. It's going to make you sleepy, and it's telling your body that it's time to go to sleep. One thing that people say, you see it a lot in infomercials now, is that melatonin is a sleep aid. that you can take melatonin and it'll put you to sleep for the rest of the night. That is not true. Melatonin should not be taken if you're having problems sleeping through the night. Melatonin is used as a supplement for people that are on shift work or are taking long flights where there's a big time difference. Melatonin will help your sleep-wake cycle get back on track. It will not keep you asleep through the night. That's not what it's used for. Now, another thing that this pineal gland does is it's going to produce a substance called pineal sand that really lights up when you take an x-ray, and radiologists can use that as a really easy, distinguished landmark if they're taking images of the brain. Now, our next clinical case on page 13 deals with this levels of melatonin that the body is producing. And this is called seasonal affective disorder. This disorder is very common in areas where there's not a lot of sunlight, more northern territories, for example, like Alaska, Canada, places like that, where there's long periods of darkness followed by long periods of daylight. When there's not a lot of daylight, it's going to increase the production of that melatonin. That melatonin makes you drowsy and everything, but if you have increased amounts of this melatonin, you could have feelings of hopelessness, increased appetite, increased sleep, or lethargy. One way to treat seasonal affective disorder is light therapy. This is what this individual is doing in this picture. She has light shining on her. Some forms of tanning beds can also be good for seasonal affective disorder. Other than that, really the only thing you can do is treat the symptoms with some sort of antidepressant medications. The next organ that we're going to look at is going to be the thyroid gland. This is going to be the largest of the endocrine organs that are specific for endocrine activities. It's going to be immediately inferior to the thyroid cartilage in your larynx and just anterior to the trachea. So it's going to sit right on top of that trachea. That thyroid gland has two lobes, a left and a right lobe, and those lobes are going to be connected together by an area called the isthmus. Now, this picture is figure 1.5 in your lab manual. This is a picture of the thyroid glands under a microscope. What you're going to see in the thyroid gland are these hollow spherical structures called follicles. So each one of these weird shaped circles is a follicle, and these follicles are going to be outlined by cells called follicular cells. So each one of these individual cells that make up that follicle is a follicular cell. Those cells are going to surround a central cavity called a lumen. The lumen is that white space in the middle of this follicle. And what these follicular cells do is they take amino acids and iodine from the blood. They reformulate that into a substance called colloid. Now, that colloid is going to be a combination of thyroglobulins and iodine, which is this reformulated substance. The colloid is going to be deposited into the lumen of that follicle. If you look at the slide, the colloid's going to stain sort of a light pink color, and it's going to hang out in the middle of that follicle. The colloid is going to be a precursor to the thyroid hormone. There's a couple of different thyroid hormones that I want you to know. Triiodothyronin and thyroxine are the two types of thyroid hormones that I want you to know. In the case of these two hormones, I'm okay with you using the abbreviated terms, T3 for triiodothyronin and T4 for thyroxine. You can use those. Both of these types of thyroid hormone are going to do the same thing. They're going to increase the basal metabolic rate, which is how your body is going to metabolize foods for energy. It's going to affect how proteins are formed, how they're synthesized, and then it's going to increase the body's sensitivity to catecholamine, which are hormones that are produced in the adrenal gland, and we'll talk about those in just a little bit. Now, we looked at the follicular cells that make up those follicles in the thyroid gland, but there's also another population of cells that you're going to see in the thyroid gland called parafollicular cells. These parafollicular cells are going to be in between the follicles, these little clumps of cells that are in between the follicular cells. These cells, these groups of cells, are going to secrete a hormone called calcitonin. And calcitonin is going to decrease blood calcium levels. If you look on table 1.4, table 1.4 lists out the different hormones that are produced in the thyroid and the parathyroid gland. Calcitonin got left off of this table, so I need you to add that to table 1.4. If you just write it at the very bottom of this table, that should be sufficient. So right underneath this table, write calcitonin and then dash, and for its function, I want you to put decreases blood calcium levels in the function. So on table 1.4, make sure you add calcitonin into this table because I will, that is fair game for the practical. Now, this calcitonin is going to be decreasing the blood calcium levels in a certain way. If the blood calcium levels are too high, that calcitonin is going to be released. The calcitonin is going to go to the bones and it's going to inhibit a cell in the bones called osteoclasts. Osteoclasts are the specific cells in the bone that break down bone to release calcium. So when this calcitonin goes to those osteoclasts and inhibits them, it shuts them off, those cells cannot break down any more bone and they cannot release any more calcium into the blood. If we're not releasing any more calcium, it'll decrease those blood calcium levels. The next gland that I want you to look at is called the parathyroid gland. These are 4 small glands that are embedded on the posterior side of the thyroid gland. And if you go to figure 1.5, you can see these little yellow circles are the parathyroid glands. There can be 4, there can be up to 8 of these parathyroid glands on that posterior side. It doesn't matter how many there are. If you look at the slide of the thyroid, the parathyroid gland is also going to be on that slide because they're so close together. And that parathyroid gland is going to stain one solid dark color on that slide. It doesn't have any follicles, it doesn't have any follicular cells. It's just going to look like one dark mass on that slide. Here you can see the thyroid with all the follicles. Here's the parathyroid gland. Now this organ is going to produce parathyroid hormone. Parathyroid hormone is going to do just the opposite of calcitonin from the thyroid. So calcitonin decreases blood calcium levels. Parathyroid hormone is going to increase blood calcium levels. So it's going to go right back to those osteoclasts. If there's not enough calcium in the blood, that parathyroid hormone will go to those osteoclasts in the bone, and it'll tell those osteoclasts to increase their activity. Let's go ahead and break down some more bone. If those osteoclasts increase, it'll break down more bone and it'll release more calcium into the body, so then it'll increase those blood calcium levels. That parathyroid hormone is also going to go to the kidneys, and it's going to tell the kidneys to reabsorb calcium from the blood. And it's also going to go to the small intestines and tell them to enhance calcium absorption through digestion. So let's turn to page 13 and look at some of the clinical cases that are affecting the thyroid gland. The first one we're going to look at is a condition called a goiter. This is a type of hypothyroidism, so the body's not getting enough of that thyroid hormone. The most common cause of a goiter is going to be lack of dietary iodine. Either it's not in the soil or the person's not eating enough shellfish, which contain iodine. That body needs iodine to produce the thyroid hormone. Iodine is essential for the production of that thyroid hormone. So if you're not getting enough iodine, you're not properly making enough thyroid hormone. When the body senses that there's not enough thyroid hormone, the pituitary gland is going to go into overdrive, and that pituitary gland in the brain is going to release more thyroid stimulating hormone in hopes to stimulate the thyroid to produce more thyroid hormone. But the problem isn't with the thyroid gland, it's with the body not getting enough iodine. So what's happening is that pituitary gland is sending more thyroid stimulating hormone to that thyroid gland to help stimulate it, but it's not stimulating the production of the thyroid hormone. All it's doing is causing that thyroid gland to overgrow, and it's causing that thyroid to get larger and larger and larger. It's causing that thyroid gland to get larger in hopes that it will produce more thyroid hormone. So that's what you see here in this picture. This is a very, very severe goiter. It starts off relatively small and then can grow if it's not taken care of. But in this case, this individual was getting a lot of thyroid stimulating hormone, which causes that goiter to grow and grow and grow and grow and grow. If it's not taken care of, it can cut off the airway of the individual. Now, a lot of the times you won't see goiters anymore in the United States. It's very uncommon to see an individual with a very, very large goiter anyway, because most of the food processing companies add iodine to their table salt, and everything has table salt in it. So individuals are getting plenty amounts of iodine in the salts that they eat on a day-to-day basis. The next clinical case is called Graves' disease, and this is a type of hyperthyroidism, so the body's producing too much thyroid hormone. Graves' disease is an autoimmune disease where the antibodies that normally ward off bad substances that get in your body turn and start to attack the body itself. In this case, Graves' disease is an autoimmune disease where the antibodies are going to attack the thyroid follicles, and when they attack the thyroid follicles, they start to mimic thyroid stimulating hormone. When these antibodies mimic thyroid stimulating hormone, instead of destroying the follicle, it's actually causing that thyroid to produce more thyroid hormone, and more and more and more thyroid hormone. So that's where the hypersecretion comes from. Some of the symptoms for Graves' disease is double vision. Exophthalmos is the protrusion of the eyeballs from the sockets, difficulty concentrating, and restlessness. The next endocrine organ is going to be the adrenal glands. The adrenal glands are going to sit directly superior to the kidneys, so right on top of the kidneys. There is one adrenal gland on top of each of the kidneys. And just like the pituitary glands, the adrenal glands are going to look relatively different from the outer part of the adrenal gland to the middle of the adrenal gland, because they have different embryological origins. If you look at one of the adrenal glands and cut it open, around the edge is going to be an area called the adrenal cortex. This is going to have more of a glandular appearance, so it'll stain a little bit darker on a microscope. And then in the middle of the adrenal gland is going to be an area called the adrenal medulla. This is going to have more of a neural appearance, so it's going to stain a little bit lighter on the slide. Now, if we look at the adrenal cortex first, the adrenal cortex is going to have 3 specific regions or zones, and each one of these regions is going to produce a different group of steroid hormones. So first, let me describe what this slide looks like in your lab manual. What we're going to have at the top here is a lighter area. This is outside of the organ. This isn't part of the organ. This is just the area around that adrenal gland. So that's going to be where we're going to start. This first thin dark line at the very top, this is going to be the capsule for the adrenal gland. This is just the connective tissue that's protecting that adrenal gland. And then right underneath that, there's going to be a thin area called the zona glomerulosa. It's a little bit darker in color than the area below it, and it's pretty thin, but it's going to be right underneath that capsule. The zona glomerulosa is going to produce a group of steroid hormones called mineralocorticoids. Mineralocorticoids. Now, there are several different types of mineralocorticoids. I don't want you to know the specific hormones. I just want you to know what this group of hormones does. Mineralocorticoids are going to activate reabsorption of sodium in the kidneys. Anytime sodium is getting reabsorbed, the water is going to follow the sodium. So when you reabsorb sodium, you're also reabsorbing water in the kidneys. It's also going to help secrete potassium in the kidneys. So this is really going to regulate the ratio of sodium and potassium in the blood by what the kidneys are secreting or not secreting. The second region of the adrenal cortex is called the zona fasciculata. It's slightly larger than the zona glomerulosa, and it does not stain as dark. So you can see it's a lot lighter area in this region. This area is going to produce a group of steroid hormones called glucocorticoids. These types of hormones are going to stimulate the liver to produce glucose through a process called gluconeogenesis. Glucocorticoids is also going to promote lipolysis and proteolysis. This is going to be the breakdown of lipids and also the breakdown of proteins into smaller structures like amino acids. The deepest region in the adrenal cortex is going to be the zona reticularis. This area is darker than the zona fasciculata, and it's also going to be slightly larger. This is going to be the last region in that renal cortex, in that adrenal cortex, and right before you hit the medulla, the adrenal medulla. This area is going to produce glucocorticoids, and it's also going to produce gonadocorticoids. We've already talked about glucocorticoids, so we're going to focus on the gonadocorticoids. The main gonadocorticoid hormone that I want you to know is a hormone called androgens. Androgens is thought to be responsible for the sex drive. Androgens is a male hormone that is sort of the precursor to testosterone, but in women, androgens can also be converted into estrogen. So it can do a couple of different things. Now, the last area in this adrenal gland is the deepest area, which is that adrenal medulla. The adrenal medulla is going to be composed of a specific type of cell called chromaffin cells. And chromaffin cells are going to produce catecholamines. The two types of catecholamines that I want you to know are epinephrine and norepinephrine. Both epinephrine and norepinephrine are going to be produced in response to your fight or flight response. So these two hormones can act on your blood vessels as vasoconstrictors and help promote gluconeogenesis and break down that glucose if you're really scared and need that boost of energy really quickly. The next organs we're going to talk about have an endocrine function, but they also play a role in one of the other body systems. The pancreas is going to also be part of the digestive system. The majority of the cells that you're going to see in the pancreas are called pancreatic acini cells, and these are going to be specific to secreting pancreatic juices for digestion. If you look at the slide, all of these darkly stained blocky cells are going to be the pancreatic acini cells. That's going to be the majority of them. But every now and again, when you look at the slide, you're going to see this mass of lighter colored cells. This area, this mass of cells, is called a pancreatic islet, and it's literally an island of these endocrine cells that are dispersed throughout the acini cells. There are 4 different types of cells that make up this pancreatic islet. I only want you to know the functions of 2 of these cells. The first one is going to be alpha cells, and alpha cells are going to produce a hormone called glucagon. Glucagon is going to increase blood glucose levels by stimulating the breakdown of glycogen into glucose in the liver. So in the liver you have a substance called glycogen, which is your stored energy, and that glucagon is going to go to that glycogen and break it down so you could use that glucose for energy. The other type of cells that you're going to see in this pancreatic islet is called beta cells. And beta cells are going to produce insulin, which are going to decrease blood glucose levels. It's going to do this by enhancing the glucose transport into the body of the cells. It's going to allow all the cells to take up more glucose, especially the fat and muscle cells. It'll really uptake that glucose. It's also going to stimulate the liver to form glycogen from glucose. This insulin is going to be at its highest right after you eat and you're taking in a lot of nutrients and you're taking in more glucose. So once you eat and you take in all this glucose and your blood glucose levels rise, that insulin is going to increase and promote that glucose to be stored in other areas of the body. This is going to bring us to our last clinical case called diabetes mellitus. Make sure you write out the full name on the practical because there is another type of diabetes that we talked about at the beginning of this video. So when we're talking about the pancreas, diabetes mellitus is the condition that we're talking about. Now this condition is a result of increased blood glucose levels, and this can happen in 3 different ways. Now the first type of diabetes mellitus is type 1 diabetes mellitus, and this is a hyposecretion of insulin by the pancreas. So the pancreas is not producing enough insulin. If you don't have enough insulin, you don't have that hormone that tells the other body cells to uptake that glucose. This is an autoimmune disorder where your antibodies are attacking those beta cells. And when it attacks those beta cells, the beta cells can't produce insulin anymore, so your body can't produce it. In a case of type 1 diabetes, the individual does have to take insulin shots, insulin injections regularly, especially after they eat. For the rest of their life, they'll have to take insulin injections. The second type of diabetes mellitus is type 2 diabetes. And this is where the body is producing insulin. It might not be producing enough insulin, or the rest of the cells might not be able to use the insulin the body is producing, but the body is actually making some insulin. A lot of the causes for type 2 diabetes is an increase in weight. Overweight individuals have problems with type 2 diabetes. That's why this is called non-insulin dependent diabetes. In these cases, individuals that have type 2 diabetes can take control of this condition and reverse this type of diabetes if they just alter their diet. The last type of diabetes is called gestational diabetes, and this is a temporary condition that develops when a woman is in her 2nd or 3rd trimester. Only about 2% of pregnancies result in gestational diabetes. This type of diabetes usually resolves itself after the birth of the infant, but sometimes the woman can develop or have a higher chance of type 2 diabetes if they did have gestational diabetes. The next organ we're going to look at is the ovaries. The ovary is mostly a reproductive organ, but it does secrete some hormones, so it can also be an endocrine organ as well. The ovaries is a type of gonads in the females, and these ovaries do not form and serve as an endocrine function until the individual hits puberty. Before puberty, the ovary is not an endocrine organ. But once the individual hits puberty, there are a couple structures in the ovary that will start to produce hormones. The first structure that I want you to notice are these large circles with the white lumen in the middle. These are called follicles. Inside of the follicle is where the egg is developing. The follicles are going to produce estrogen once that female hits puberty. Estrogen is going to play into the secondary sex characteristics. It's also going to be involved with the maturation of the reproductive organs and the maturation of the eggs. It's also going to deal with the cyclic changes that you see in the uterus. Now the next structure in the ovary is this really large structure right here. This is called the corpus luteum. The corpus luteum is filled with tissue that will eventually become scar tissue, and you can see it stains a little bit pinker on the slide. The corpus luteum is going to produce a hormone called progesterone, which is also going to play into the secondary sex characteristics, and it's also going to be involved with the cyclic changes that you see in the uterus. The gonads in males are called the testes, and again, the testes are not going to be an endocrine organ until the male hits puberty. What we're going to see in the testes is some cells called interstitial cells. That's this little group of cells right here. Interstitial cells are going to be in between these large tubes called seminiferous tubules. The seminiferous tubules are the area where the sperm matures. Interstitial cells are going to be in between those tubes. Interstitial cells do not have anything to do with the sperm. All they are doing is producing the hormone testosterone. Testosterone is going to play into the sex characteristics, the secondary sex characteristics, the maturation of the reproductive organs. It's going to be responsible for the male libido or the male sex drive. And then it's also going to deal with sperm production and how many sperm are produced. The last organ we're going to look at is called the thymus. This is going to be located in the superior mediastinum, right on top of the large blood vessels that are leaving and coming into the heart. The thymus is going to be mostly a lymphatic organ. It has a lot to do with the immune system, but it does produce a hormone, so you can place it in the endocrine system as well. The thymus is going to be composed of two lobes, and these lobes are going to be separated into smaller lobules. This is a lobule right here. There's another lobule over here. And those lobules are going to be separated by septae, which are these long clefts that are going through and separating those two areas. In each one of these lobules, you're going to have a darker cortex around the edge and a lighter medulla on the inside. So here's the entire lobule. You have the dark cortex around the edge and the lighter medulla on the inside. Now, as far as endocrine function goes, the thymus is going to secrete a hormone called thymoxines, and thymoxines are going to play into T lymphocyte maturation. T lymphocytes are an important cell that play a role in your immune system, so the thymoxines are going to help mature these T lymphocytes so then they can help destroy any foreign substances that get into the body. Now, the thymus is going to be really large in children. They need more of this lymphatic function. They need to produce more of these cells to fight off infections and things like that. But as you get older, your body starts to produce antibodies, and the antibodies will attack foreign substances. So as you get older, the antibodies sort of take the role of the thymus, and you don't really need the thymus anymore. You don't need as much function from the thymus, and the thymus will start to turn into adipose tissue, turn into fat. So it's really large when you're a child, but as you get older and start to produce antibodies, you don't need that function anymore, and it starts to turn to fat.